So welcome to our latest Spotlight on Stigma webinar. Today we're having a focus on a universal precautions approach to stigma reduction. My name's Carla Treloar. I'm from the Centre for Social Research in Health, and I pay respects to elders past and present and acknowledge the traditional custodians of the land that I'm on, which is the Bidjigal people of the Eora Nation. And as we're talking about stigma, we must also acknowledge the additional burdens carried by Aboriginal and Torres Strait Islanders and First Nations people around the world in relation to racism, institutional racism, and in our corner of the world, bloodborne virus and STIs. So today, we've got some, as always, two fabulous speakers to dig into this notion of a potential universal precautions approach to stigma reduction. So I'm going to introduce the speakers, and then I'm going to do a little quick intro of what we're thinking about with universal precautions before handing over. So I want to welcome Gemma Nourse from the Australian Research Centre in Sex, Health and Society at La Trobe University. And Gemma, along with Emily Lenton and Adrian Ferrugia and Kate Sear and Suzanne Fraser at Archers, are part of this large project on a universal precautions approach. Gemma is a research associate with Archers, has been studying in her PhD issues about co-constitution of performance and image-enhancing drugs, health and masculinity, and is now working in the hepatitis C space. After Gemma, so thrilled to have Mark Orr with us here, and I reached out to Mark to specifically talk about this universal precautions approach because of his experiences over a range of different areas that we're primarily interested in. Mark's director and president of AFAO, now called Health Equity Matters, but is also CEO of a large mental health service provider, Flourish Australia, has also worked in disability and LGBTQ health services. So with that expertise across so many different areas of life, thought Mark was so well placed to speak about this, and also bringing in his role on the steering committee of the National Mental Health Stigma and Discrimination Reduction Strategy, which will be launched later this year, I believe. Yeah, great. So I'm going to get into a quick intro and then hand over to Gemma and then to Mark. So as always, the share screen efforts start here, and let's see if I can do it without stuffing it up. Okay, am I looking okay, Eleanor?
Yeah.
Great. So very pleased to talk through this project that our centre is leading in collaboration with a lot of other groups, which I'll show you in a second, on a trial of a universal precautions approach to stigma reduction in the BBV and STI field. So this project is funded by the Australian Government Department of Health, and we're very thankful for their contribution. It involves us here at CSRH, the Archers team, but also the Burnett Institute and the Kirby Institute, and with our wonderful community and health sector partners as listed on the slide. We, as this seminar series goes along of putting community at the centre of all of our efforts, we're absolutely committed to working in partnership on this universal precautions stigma reduction project. So the background to this, we all know, hopefully, that the Australian National Strategies for BBVs and STIs have long had this commitment and goal of eliminating the negative impact of stigma, discrimination and legal and human rights issues on people's health across HIV, Hep B, Hep C and STIs, and the Aboriginal and Torres Strait Islander strategy. And because this is funded by the Department of Health, we're obviously very interested in stigma in healthcare. We're connecting here our concerns about stigma with movements elsewhere in global notions of what makes high quality health systems. And this is from a Lancet commission published 5 years ago now, where they're drawing attention to quality of care being worst for vulnerable groups, including those with stigmatized conditions. So we're using other levers to help us pitch this idea that stigma reduction is really important. We're also drawing on this work from the US which over a general population sample of US adults, in their analysis found 93 different identities, conditions and attributes as attracting stigma. Most people indicated they lived with at least one of this list of 93, and 90% of participants reported more than one, with an average of 6. So their conclusions included that stigma affects a substantial proportion or segment of the US population at any given time, with most individuals being stigmatized at some point in their lives. So obviously we're very interested in this from a BBV and STI field. And even within that, there's so many different ways in which we could be thinking about, or people are living the experience of stigma, as well as these 90 other identities, conditions and attributes that all want a piece of the stigma reduction cherry. So we published a commentary last year where we outlined the kind of thinking behind what might be a universal precautions approach to stigma, that these other sectors also want stigma reduction and elimination: mental health, obesity, poverty, skin conditions, all sorts of things. So it's not feasible or realistic or consistent with universal access to healthcare to expect health systems to respond to HIV, hepatitis C, hepatitis B, mental health in all its varieties, obesity, skin conditions, poverty, dentition, all the possible things that could be wanting action on stigma reduction. So we were thinking about ways that we could produce sustainable systemic change for tackling stigmatizing conditions, policies and practices across all areas of stigma. So we're proposing that a universal precautions approach could, at its base, assume that everyone, all people, are fearful of exclusion or poor treatment on the basis of one or more things going on in their lives, that multiple settings and situations might give rise to stigma, and all of this undermines the provision of effective and quality healthcare. So we hope in this project to develop and trial a world-first systemic approach to stigma reduction based on this unifying logic of universal precautions. Everyone might feel stigmatized at some point in their lives, and we should be thinking about ways in which the health system can respond to that, rather than cutting it up into finer and finer slices of disease, condition, identity-specific approaches. And in doing this, we want to leverage precepts of equity, access, and quality to produce scalable initiatives. So this project will run, we're just finishing the first year of 4. And what we're going to hear about today is some results from this first aspect of conducting discovery research to support what might become interventions down the road. We've got some co-design interventions, co-design for interventions occurring later this year, and then 2024 and beyond, we'll move into implementing and trialing a range of prototype interventions that we can then produce scale-up plans and toolkits for other people to pick up. And our aim number 5 here, providing workforce development. Well, this webinar is one of those activities to produce or to provide workforce development, research literacy in this area. So that is the end of my little introduction. So now I'm going to hand over to Gemma and make sure you can screen share, and away you go. So welcome, Gemma. Lovely to have you here. Can't wait to hear what you've got to say.
Hi, everyone. You can see my screen okay? Great. I'll get going. So thanks very much for having me today. My name's Gemma Nourse. I'm a research associate with the Drugs, Gender and Sexuality program at Archers. And today I'm presenting some preliminary analysis from our interviews with key stakeholders, which we've titled Space, Time and Funding, Addressing Healthcare Stigma Beyond Interpersonal Interactions. So I'd like to begin by acknowledging the traditional owners of country throughout Australia and to recognise their continuing connection to land, waters and culture. And I pay my respects to their elders, past and present. Here are the details of the people involved in this project, and I don't have time to go through them all, but I would just like to say thank you very much to the 20 people who we've interviewed, who generously gave their time to take part in this research. So our presentation today will present a preliminary analysis of these three key themes. The first involves participant discussions of the importance of space to the production of stigma and how space might be considered in stigma reduction efforts. The second is about healthcare service environments and poorly designed healthcare technologies. And the third involves discussions of the lack of time in health service encounters, in large part caused by inadequate funding. So we argue that these are important issues to consider in developing a universal precautions approach to stigma reduction. I'll begin by giving a brief background and literature review, followed by an outline of our approach. We'll then give an update of our progress so far and a brief mention of our methods taken before presenting some interview data. And then we'll offer some concluding thoughts and prompts that might help to inform discussion later on in today's session. So by way of background, it's well known that stigma related to bloodborne viruses and sexually transmitted infections impacts healthcare. Interpersonal interactions in healthcare settings have been a big focus within this research. As an example, some research has demonstrated the ways in which people experience changed attitudes, altered demeanours, terse voices, and the avoidance of eye contact after disclosing their hepatitis C status to healthcare workers. Harris and colleagues observed that in research, there's a tendency for stigma to be produced and located in relation to individuals as a matter of how discriminatory beliefs and attitudes shape social and self-identity, and that positioning stigma in this way obscures how stigma might be alternatively located and produced in wider social, political, and economic contexts. So this focus on individual behaviours and interpersonal interactions is, of course, an important area of research and one to draw on in designing this intervention. And we hope to build on it by broadening analysis beyond the interpersonal as well. So to do so, we turn to literature that's attended to the relationships between space, technologies, and time. And we're doing this because these three themes emerge quite strongly from the data. So we're turning to scholarship such as Farrugia's article exploring young men's experiences of taking the drug MDMA. In it, Farrugia uses the concept of the assemblage developed by Deleuze and Guattari to examine the interactions between human and non-human bodies and their relationships to spatial temporal arrangements that work to produce experiences of pleasure, connection, and play.
Gemma, I think you might be one slide ahead.
Oh, thank you. Thanks very much. We also draw on Suzanne Fraser's 2006 article, which considers methadone maintenance treatment as a temporal and spatial phenomenon, one that helps materialise particular methadone subjects, often the very kinds considered undesirable, that is unproductive, the disorderly, and the illicit. And we're also drawing on Fraser and colleagues' 2017 article in which the authors pose stigma as a performative biopolitical technology of power to help conceptualise stigma not merely as a side effect of misconceptions or of individual proclivities towards aggressive, exclusionary judgmentalism, but instead as it relates to functions of power and governmentality. So our approach mobilises insights from contemporary sociological AOD research that draws on, broadly speaking, new materialist concepts, such as the literature reviewed in the previous slide, to analyse all social phenomena, such as individual people, attitudes, institutional processes, and even spatial arrangements as mutually co-productive or assembled. For our purposes, this approach aims to broaden the analytical lens of stigma research beyond interpersonal interactions, approach stigma as produced by the interplay of healthcare service design, including its physical environments, and to see stigma not as pre-existing interactions, but as emerging through relationships with other forces, such as funding, time, physical spaces, and technologies. So in terms of progress so far, we've conducted interviews with 20 key informants, which were done between December of last year and April of this year. These were semi-structured interviews, 60 to 90 minutes in length, and have been subsequently transcribed, de-identified, and coded. And I'd love to say more about this, but don't have time, unfortunately. But we'd also just like to say that we're currently recruiting for the second phase of interviews with clinical and non-clinical healthcare staff. So if you'd like to be involved, please get in contact with myself or my colleague, Emily Lenton, whose email address is on this slide here. Okay, so now we're going to present some selected data organised around these three deeply interconnected issues of space, service environments and technologies, and time. So to begin with, issues of space were discussed in a variety of ways by participants. Some discussed space in terms of geographical location of healthcare services and clinics, and observed how the location of the health service affects how stigma manifests in ways that I know will be familiar to our audience today. So for instance, some discussed how particular geographical locations such as the ACT can create ease of access to government for advocacy purposes. Others discussed ways in which particular diseases such as hepatitis B or C can be more or less prevalent in specific areas of a state, depending on a variety of factors. So these accounts highlight ways in which geography multiply impacts on and works to co-produce stigma. P10, who works in primary health, gives an example here when they say, wealthy guys in inner Sydney, they will keep getting good service. And clearly that's where the Mardi Gras is, so not a huge amount of stigma. But then elsewhere, once you go to southwest Sydney and come to a place like Adelaide, yeah, there's quite a lot of stigma. Uptake of BBV testing and treatment progressively goes down. So inner Sydney is like 90%. And as you go out into the middle suburbs, it gets more around 70 to 80%. And then you go to the outer suburbs and it's more around 40%, you know, and it's purely economics. This issue of economics or funding emerges throughout the data as a key co-constitutive factor in the production of stigma, as we'll see today. Another theme to emerge from the data is that of specific challenges to healthcare services located regionally and rurally in addressing BBV and STI-related stigma. P14 discusses some of these challenges in this excerpt where they say, I know that there are people who don't have a regular GP or they live in places where it's very difficult to get in to see one. Their books are closed. I think one of the barriers with people seeking healthcare professional support is, who knows I'm here? Who's going to find out why I'm here in the local community? So yes, my grand plan of training doctors better and all those sorts of things is great, but it operates in a community and it's who's in the waiting room, who's collecting the pathology, who's on the reception desk. And in the city, it can be a little more anonymous, but in rural and remote settings, everyone knows everybody. In addition to issues relating to funding for regional and remote health, this excerpt also highlights ways in which smaller communities must contend with issues of privacy and anonymity in accessing potentially sensitive BBV or STI-related healthcare and how these may co-produce experiences of stigma. So continuing with this theme of space, some participants suggested the need for flexibility in health service design and location to help reduce stigma. For instance, P12 says, I think you do need to have these outreach services for people. People need to be able to drop in as they perhaps need to. Systems have to be a little bit more flexible, I think, in how they approach these populations because of the rigidity of systems can be very problematic. In being more flexible, you're kind of meeting people where they're at. The patients we work with are complicated, but we have relatively lower caseloads, which allows staff to have some flexibility to work with and collaborate with the patient to achieve the best outcome and to do things in timeframes or at times a bit more suitable to them, the patient. And we can be a little bit more, like we're not as rigid, I guess, in how we approach patient appointments and so forth. Heard more typically in regards to being more accepting of where people are at with, say, a treatment journey. Here, P12 suggests the need for services to more literally meet people where they're at. That is, they highlight a need to reconceptualize the health service as spatially more flexible so that people are better able to access services. I want to highlight too, this participant's mention of lower caseloads as being a key factor aiding this reconceptualization of space and time, which of course relates to matters of funding. A number of participants offered ideas about alternative conceptions of healthcare spaces, including pop-up clinics or increasing patients' health literacy so that they can self-test at home. These participants saw these alternatives as helping to reduce stigma by providing healthcare options located outside of traditional settings, which, as I'll now demonstrate, were understood by many participants as quite hostile places for particular individuals or communities. So I'm moving now to our second thematic concern, which is to do with the impact of service environments and technologies on the production of stigma. A number of participants observed how the service environment and aspects of its physical design may affect people's experiences of accessing healthcare. When asked what the priority changes are for addressing BBV or STI-related stigma and discrimination, P15 makes similar observations to those offered on the previous slide in regards to meeting people where they're at, where they say, I think one of the first things we should do in health is to actually have services open at times when people could go that suits them, and for them to be open later and earlier and in places where people go and they feel comfortable. And then they continue, probably the other thing I would do is remove a lot of the screens and the barriers for people, like just the physical barriers. I mean, often we see services that have physical barriers for safety reasons and those sorts of things. And I always think that's an overreach. And some of those services look like jails, right? They're not very welcoming, don't have a place for people to sit, you know, it's not like a caring place. Another participant also commented on this aspect of health service design, observing that health services often have screens that come up and down and lock and unlock and say it's like a jail, right? So in addition to the ways in which design features such as screens and barriers contribute to feeling unwelcome in some traditional healthcare settings, many participants also brought attention to things like the design of waiting rooms and emphasised the need to ensure there's appropriate seating for a range of bodies and that waiting rooms are designed with privacy in mind. The positive effect of having items around that indicate to people from various intersecting stigmatised or marginalised communities that they're welcome, including having First Nations artwork on the wall, brochures and posters in other languages, as well as LGBTIQA posters and rainbow lanyards visible. And another issue raised was that of signs and signage by a few participants, but one gave the example of going to an eye hospital and noticing that the signage was terrible and not designed for people with vision impairment. So these non-human elements of service design were noted by participants as playing an important role in how these services were potentially experienced by those accessing them. Some participants reflected on ways in which specific technologies co-constitute stigma. P8, who works in a hospital, discusses the effects of medical software, and they say whatever software you have or whatever application you have doesn't have enough spaces for some names, or it doesn't have the right accents to be able to spell it properly. So you might have someone who's got like a Chinese name, but they use an English name as their preferred name, and that Anglo name might be what appears on their name badge or roster, but it's not what appears in the medical record. So it can cause staff to become exasperated, and they say, I can never get a hold of this patient's medical record, you know, this person, they've just got a difficult name. When in fact, it's just that the systems don't talk to each other and allow you to save all these names. P15 likewise offers a reflection on the design of needle and syringe dispensing machines at hospitals and how these technologies could be more thoughtfully considered for those using it. And they say, when I look at some of the NSP machines we have around in some of the hospitals, you know, now they've got things like rain covers over them so people can actually get a clean syringe when it's raining. You know, it's that sort of thing, like some real structural things I think we can change to just say, like, you're welcome here, right? And you're welcome in the service, you know. These data demonstrate some of the ways in which stigma can be conceptualized as made through or emerging from the relationships between human and non-human elements. So, for instance, time-poor and busy hospital staff trying to find a person's name or record in a system that isn't designed to capture the diversity of patient names, and the ways in which that frustration might inadvertently impact on or be brought to the patients themselves. In some instances, the production of stigmatising health service encounters was understood as an issue of funding. Some emphasised that many people employed in health services, including hospitals and GP clinics, want to provide good, thorough and non-stigmatising healthcare, but that this is made difficult to impossible due to being overworked, understaffed, and therefore lacking in the critical resource of time. Time emerges from the data set as necessary in providing non-stigmatizing healthcare. And I've already flagged some of the ways this was discussed, as in the example of lower caseloads given earlier, where time is seen to produce greater flexibility, greater capacity to attend to complexity. It allows for reflection, discussion, and better supervision. These things are not possible in workplace environments where people are stretched. For instance, P1 says, it's not viable now for many general practitioners to work. They're overworked, they don't get paid for their time. Person-centred care is very difficult to achieve these days in the Australian healthcare system because everybody's so busy and everybody's so stressed and they're short-staffed, like you wouldn't believe. Likewise, P8 makes an important observation here when they reflect on the very real impact of lack of funding on the standard of service able to be offered. And they say there's a lot of material constraints on people behaving as well as they should, as well as we should. And it's all about working conditions. People can't be at their best when they're overworked and tired, and it would be costly. But we are kind of run lean, running on minimum staffing that's required to do a good job on a good day. And then most of the time it's not a great day and people get sick and you go below minimum staffing. And then you wonder why people aren't stopping to have that tricky conversation with a patient's relative in the corridor, and why they're not making that phone call to the patient's son or daughter who's been leaving messages for the nurses all day. So I think that would actually be a much better investment than a kind of yet another set of behavioural standards that we're expected to comply with, which we already want to do anyway. Here, P8 crucially points out the need to conceptualise of stigma or poor healthcare as sometimes emerging from a broader structural context in which healthcare is underfunded, rather than seeing it solely as a product of staff attitudes or beliefs. P8 emphasises here and elsewhere in their interview that most of the staff they know and work with genuinely want to provide better, more thorough and person-centred care than they have the time for. So I want to finish today with this data from the interview with P17, to demonstrate an instance of time, space and stigma coming together. Recalling Suzanne Fraser's 2006 article on the chronotype of the methadone queue, here P17 illustrates ways in which the space of the pharmacy and its relationship to the space of the mall within which it's located and time are brought together to co-constitute particular clients as less important or less deserving of attention and care. P17 says, "It became clear to me that the way that our process was set up was very different for particular people than it was for anybody else. And so if any of the clients who were utilising the methadone program, for instance, had come in and said, 'I'm here to get something for eczema,' we would provide them with the care thereafter far more rapidly than when they would come in for methadone or buprenorphine. So it just struck me then, why are we doing it this way? And like we even had rules. So the pharmacy had a main street entry and a mall entry. And we would actually have in the contract of agreement for the methadone program that they had to come in through the mall entry only. And I said, this is not right. We can't do that. Like, how can we do this? And so we started to change it. So to conclude, we've aimed today to draw attention to how space, technology, service design, time and funding are mutually implicated forces, and that stigma can be conceptualised as emerging from the ways in which these forces come together. By focusing on these related issues, we've examined how an expansive notion of stigma, such as that proposed by the Universal Precautions approach, can broaden our understanding beyond interpersonal interactions alone, and have hopefully also demonstrated today the importance of doing so. And just to finish, we have some questions here to help prompt reflection or discussion. They're up on the screen, but I'll just quickly run through them. So can you think of examples that speak to issues of space or time from your own professional experience? How do issues relating to space impact the experiences of clients in healthcare? how do issues relating to time impact client experiences? How do the technologies we rely on for service delivery shape client experiences? And whether people have examples of how stigma can be addressed by attention to space, technology, and time.
Thanks.
Thanks very much.
Thank you, and great questions. Are you able to pop them in the chat as well?
Yeah.
If you want to think about them, and we can come back to discussing those. Okay. Just ask people to mute themselves. So we're going to hand over to Mark, and then we'll open up for some discussion after that. So Mark, are you ready to go? You're still on mute.
You'd think after 4 years I'd be used to it. So good to be here, and thanks for the invitation. A really, really excellent topic. And I agree with you, Carla, with all of my different hats on and all the years in the various places I've worked in, this issue of doing something universal is an important one. And when reflecting on the topic, I found it interesting that you and the team are going down this path of universal precautions. And in parallel, as you've said, there's a national mental health stigma and discrimination strategy currently being finalised, hopefully for release later in the year. And indeed, the strategy or public policy focuses for both mental health and bloodborne viruses and STIs have had this topic in them for a very long time. So good to see some stuff happening. And hopefully we'll be able to bring these things together. Just to start with, I think it's an interesting conceptualization of universal precautions. Very, very health focused, and we all know what universal precautions generally mean in terms of infection control. And in pondering the question from a mental health perspective, and in mental health, we are super, super focused on language. Is the word precautions in itself self-stigmatizing? So words that came to my mind when I was rethinking this was what we're trying to say is we need to have enabling and safe environments, or enabling and safe responses that actually prevent us getting to an episode where people, or a context or an environment where people feel stigmatized and excluded. In terms of the draft national strategy on stigma and discrimination, I think what, Gemma, you've done is really great in terms of saying, well, yes, normally we have this conversation in terms of interpersonal interactions between individuals and healthcare settings and patients. I'd want to, in terms of taking this to universal broader, I'd actually want to say that, well, let's just not stick to healthcare settings. Let's talk about all sorts of settings where people are accessing services, particularly in the health and social services sectors. Because I think whilst we do see, even in people with mental health issues, tell us, and this is from the National Stigma Report Card from a few years ago that was done by Melbourne University, Sane Australia and the Ramsay Foundation, you know, up to 60% of people with complex mental health issues, so people with diagnoses of psychosis, schizophrenia, bipolar disorder, major depression, around 6% said they had a really bad experience of healthcare settings. Worryingly, they had about the same amount of experience of stigma in mental health settings, people who are specialising in the area, and about the same amount in terms of social services. So no matter where people are turning, the same level of stigma is being experienced. So I think it's good to try and continue to open up this issue of universality. I think the other thing that the national strategy talks about are 3 types of stigma. So we've talked a bit about individualised focus or interpersonal interactions. So the strategy itself talks about structural stigma, public stigma, and self-stigma. And as you pointed out, Gemma, the complex interplay of all of those sorts of things. And so this universal approach, I think, is fantastic, because what it's really saying is we need to address all of it. We can't just do one bit of it. So if we're just stuck on workforce development and in individual attitudes and how we might change those, we're not going to get far. And I think experience tells us we don't. So we've got to come up with clever ways of actually doing all of these things together. And various actors in the systems need to be part of that, not just the individual clinician or support worker. So just reflecting on your questions, Gemma, I'll kick off the conversation and others can pick it up. I think in terms of geographic location and service design, you've touched on some of those things and some of that great data you've presented, that there are different experiences between metro, regional, rural and remote settings. And that's about simply the number of people around and who you know, partly. You've got some other options. But I also think in terms of, and you rightly start to talk about technology and digital health and digital mental health is such a bigger and growing part of our lives. And I'm not really sure we know where that's going to take us. And so I think as we start to use technology more and more, we need to be thinking about other things. And I'll come back to that in a minute. I think in terms of geographic locations, there's also issues around generalist and specialist services. And what people in those services, the clinicians, the staff in those services, know and don't know about the issues we're talking about. Of course, that then leads to conversations about cultural location. And I think it's really important for us to centre that conversation. And I think in bloodborne viruses and STIs, you know, we've done a pretty good job in some of these areas within communities which are maybe considered priority populations. So LGBTIQA plus communities, drug user communities, sex worker communities, people living with HIV. So I think those issues, we've got great experience in those places, and it's about how do we take our experience in those places and take that into new environments, into new frontiers, and that includes into the technology frontier. So that's a challenge, I think, for us to think about as we're thinking about this universal precautions approach. And so that leads to a conversation to think about socio-cultural issues, and not just in healthcare services, as I said before, because that then gives us a bigger canvas on which to intervene and to influence what's happening. In terms of service design, I think it's great to hear you, Carla, say earlier that the project's going to do some co-design later down the track. And I think from a mental health perspective, co-design and co-production are the words of the moment, and we hear it a lot. The challenge being people label things as co-design and they're not truly co-design. So it's about, I think half the challenge of the fix here is, are we involving people who may otherwise feel stigmatised or experience stigma in the design of these services? And Gemma, I think some of the data you presented was really touching on that really well about let's actually talk to people about what works. What are the interactions that we need to be facilitating through the structures we build, through the service models we have, through the waiting rooms we design, through the technology we use, where people feel welcomed, heard, and I loved the comment in that, you know, we need to create spaces that are caring and that people see are caring, not linoleum floors and harsh lights and nowhere to sit. I think in relation to client experiences of healthcare, one of the things that people in mental health services often talk about is diagnostic overshadowing. So that in a busy practice, in a busy interaction with somebody, you come in and people think there's one thing you're here to talk about, but that's just the thing that gets you in the door to have the conversation. And there are lots of other things, social issues in particular, but also maybe more complex medical or clinical issues that people probably want to talk about, but in their experience of services or healthcare, seldom get that opportunity. And that's not helped by those other issues you've talked about, Gemma, around closed books, high demand, professionals running behind, trying to do their best, but never being able to do it and feeling really bad about that. But it's also about rigidity in care models and service systems, I think, and the lack of availability to be more flexible, which does link, I think, directly, often, particularly in primary care, to funding models. And I think it's a great message from the Minister recently that they're trying to do something about funding models in primary care that create more team-based approaches. Because in mental health services, one of the things we've started to do more and more of is use more peer-based approaches in service delivery. So redesigning scopes of practice, who needs to be doing what to support the person, where do we get the most expertise, having the most impact. And that in itself actually changes culture and addresses issues of stigma in services, because you've got people who have great experience, personal lived experience, to actually deliver those services. And we know, particularly in our very great response to BBVs and STIs and HIV, that peer-based approaches are really important places. So it's about working out how we can scale up peer-based approaches in primary care and in other institutional healthcare and social service settings, I think. Just coming back to technology, I think this is one of my bugbears, is we have this rise of the use of technology in healthcare, in particular digital mental health. But we know the environment of technology, those spaces, those virtual spaces can be unsafe places. They can be places where stigma is amplified, places where people say things that they wouldn't say to your face. And so we need to be thoughtful around the use of technology and how we co-design it with people. We know technology is the way of the future for many people, not for everybody, and let's remember that. Many of the people I work with who may experience psychosis or experience paranoia aren't necessarily going to jump on that new approach to service delivery. But if it's designed well, I've talked to people and they said, yes, we do it, but we do it because we trust you. And so in my final comment about this universal precautions approach is let's think about how we can build trust in services. How do we engage with people? How do we create these kind and caring spaces? How do we create technology where people can see themselves that supports great service delivery to them? How do we create and develop care models in services that actually support staff to actually deliver great services that deliver trust? And really importantly, what are the governance structures that we need in these places? So let's just not say it's about individual clinicians and their interpersonal interactions with people. It's about what are boards doing in services that actually say, we want to have this universal precautions approach. We want services that people trust, where they feel safe, that are culturally responsive. And I think our work in bloodborne viruses and HIV over many, many years gives us some insights into how that might be done.
And Mark, your prompts here of generating heaps of comments in the chat section. So really, really useful and fantastic concepts and frameworks to help us get our teeth into this. So thank you both very much for coming from very different perspectives, but lots of things to unpack. And I think one of the first issues you raised, Mark, about, is universal precautions even the right language? I think we're absolutely open to all of this. We've got a concept, how we describe it, how we build that to meet something that makes sense to both people who use, who provide and who fund services is the challenge of making sure we can do something that's deliverable and achievable. So there's lots in the chat. I'd invite people to keep adding to that, because we're going to grab all of these points out of the chat and mull them over when we've got some time to focus on them. Is there anyone who wants to ask a clarification question or something to dig deeper into the comments that either Gemma or Mark have raised today? So if you can perhaps do this in an orderly way, put your hand up on the Zoom link, and then we can come to you that way. Tanya, over to you.
I'm just going off what Mark was saying. Like, Mark actually, there's a stigma in every area, even with the bloodborne viruses, but even with people with disabilities like myself, even for me, I still get stigmatized just because what I'm labeled with, what as my labeling, because I technically was born, it was out of my control in the way I was born, with a neurological birth defect and brain damage. And because of those labelings, like, yes, I was labelled with the mental retardation and intellectual disability, but the source of corpus callosum is a nicer way. But as Mark was saying, there's that stigmatizing there, even in technology ways, for people that don't understand how to use the technology and how to get around a system that they want to express themselves and talk, but they got that barrier of not knowing how to do it. And I had to work hard in my life to be who I am today. And I agree with Mark and Gemma, what she was talking about too. I'm just a different kettle of beast, and we gotta get our voices, lived experience heard in different ways. But thanks for the chat, the talk.
Thanks, Tanya. Mark or Gemma, did you want to respond?
I'll just say quickly, thanks, Tanya, the importance of having peer experience and peers involved in designing an intervention of this kind came up a lot in the interviews, and hopefully it's something we can write about at some point. But yeah, a lot of people really emphasize the importance of that. So I just wanted to say that, yeah.
And the only other thing I'd say, Carla, is I agree, Tanya. I think it's about, we need to be always thinking about in making these big changes, or thinking about these big changes, you know, the wide variety or diversity of people that we need to try and include in the conversation as we try and get, you know, services and systems more responsive.
Thanks. And lovely to have you on the chat. I can see you putting things in the chat about the things that need special attention for multicultural communities. What would you like to add?
Well, I'd like to say thank you for organising today's event, and Gemma and Mark. Mark, your presentation, I could actually talk for days about so many aspects you've raised, and I was just like the antenna was just going on and on, because I work in multicultural communities, and but I'd like to emphasize the things that you talked about, the structural, the self, and the environmental, which is something that we deal with all the time, because stigma doesn't have just one look of it, and it's all of those three, and each one of those three can talk about for hours about it. What is really lacking for me, and you sort of touched on it, in in terms of the peer support and stuff, but in particular, I feel there is a huge gap in our teaching around humility versus competency. We are so obsessed with competency, of getting it right all the time, and I'm advocating to have a workforce that is a lot more cluey in working with uncertainty, especially with, as the world is changing so much. War is erupting every day somewhere, and we see in Australia, you know, following the war, we see new people who have new experiences, new trauma, new ideas, and new experiences. And we don't know how to work with those uncertainty of working with people who are so different, bringing different language, bringing different ideas, bringing different, you know, we constantly in that space of not aware of our own subconscious judgments and stereotype, and that subconscious is like, when I do training, so many people talk about I'm not judgmental, I'm not, and actually we all are judgmental. It's what we do with our judgments that matters, and that's, you know, where we bring the humility to it.
Mark or Gemma, do you want to respond? And while you're thinking, just draw your attention to the questions that Gemma posed in the top of the chat as well. Really interested in if people have examples they want to put into the chat. We'd love to hear about those. But Mark or Gemma, do you want to comment on Inam's point?
Yeah, no, I think you're absolutely right. I think part of our role is to be reflecting on what we're doing as individuals, but also as services. And I think that is partly why I talk about boards being responsible for some of this as well, so that we can make explicit some of those assumptions. And you're right, we have assumptions, we have biases, and let's just name them and work with them. I'm lucky I work with 56% of my staff have a mental health issue. So every day I'm challenged in my language, in my worldview, to be better. So it's a continuous learning loop. But I do think it's also about, you know, in mental health services, we have peer-based services. I've got 200 peer workers that I employ. That again actually makes you challenge what are the values that you bring to your work from a wide variety of cultural perspectives. So I think you make some really great points.
Great. And, you know, it's obviously a really deep and complex question, looking across different conditions, identities, experiences, across different health settings, across space, time and technology. What else now? Last couple of minutes together. What else do people want to add into this conversation that we can take forward also in trying to think through what a universal precautions, or another term, we'll work on that, what that might look like in the future? So we've got some peer work comments in the chat, some space, we've got trust, we've got who's identifying as someone with lived experience or not. Would someone like to pick up on that and take these thoughts a bit further forward?
I can jump in just with one of the other things that's come out of the interviews is this idea of medical records. And I think it touches on some of the stuff that both of you have spoken about around the use of digital health. I think that there's a lot that goes on where people aren't quite sure where their information is, and that in order to build trust, it's really important to remind somebody about their privacy. And, you know, it's small acts like that, which I think affect everybody that walk through the door of a healthcare setting, that, you know, that they have the right to privacy and to understand how their health records are being used or how are they maintained. And, you know, thinking about that just as another potential intervention around, you know, building trust and, you know, showing that you actually don't want to make an assumption about the way people have sort of engaged before with healthcare services and what sort of experience that may have been like, because it may not have been very good. So it's nice to remind people that they have a right to privacy.
And just jumping on the last comment that I can see in the chat at the moment from Carol Holly about the complaints procedures needing to be accessible and trustworthy and easy to navigate, because I think the complaints process puts the work on the person with the least power in the situation to manage their energies and enthusiasms and knowledge to get through complaints processes, often to that hostile environment that they're trying to complain about. Great point, Carol, about that other structural element of what you can do if you're the individual experiencing something negative. Want to put a question to the group about, is it perhaps a cynical point, we're following on from Gemma, if the material constraints, the time, the funding is so squeezed, it means people can't be at their best. Are we ever going to find ourselves in a position where we can be at our best? Are we trying to run a race that is never endingly uphill? So Gemma and Mark, I might ask you first to think about that. Are we putting ourselves in an impossible situation for a win here?
I don't know whether, well, let's shoot for the stars, because if we only have to say, well, we'll get what we think might happen, then we'll never get anywhere, I think. And I think we need to grab opportunities, including political opportunities when they arise, to push forward. I think it's about redesigning service models, and maybe some more distribution of responsibilities and across different types of people with different types of skills. I think that might be one of the ways we can address that issue of not enough money or not enough time.
Hester, I'm trying to find a sad face to respond to your comment in the chat, and I'm just not quick enough to do it. So I've got a sad face about that. Gemma, did you want to come in?
Yeah, I guess I was just thinking, I mean, I had similar thoughts, Carla, when I was thinking about this issue of funding, and, you know, like, obviously it's a huge issue, and where to start with that is hard to know, you know, with plenty of people advocating for the need for more funding. But I suppose that was something that a lot of the interview participants spoke about, and however we kind of characterize being at our best, or whether that's possible or not, it's undeniable that many of the healthcare workers we spoke to, or people with experience in those settings, identified that as a big issue. And maybe just thinking about the presentation today that I did, you know, just the kind of political importance of highlighting something like funding, a structural issue like funding, as a component in the production of stigma, that it's not solely, it may be partly, but it's not solely to do with individuals. Individuals are operating within a funding context that makes it difficult for them to do their job well. Yeah, those are my thoughts. Yeah.
Great. Well, I think that's our time to wrap up. And I want to thank Gemma and Mark for really thought-provoking input into this discussion. We're not nearly done yet with this project. So really happy to hear from people who've got ideas or thoughts or comments. Please email me or Eleanor. Perhaps, Eleanor, if you can just drop our emails in the chat before we round out. Really happy to hear from people, because it is a really complex, juicy, tricky thing. So the more heads in this, the better. So thanks again, Gemma and Mark, and to Eleanor for organising all of this. We've got another one coming up in August about bystander interventions for stigma reduction. So look out for the advertising on that. And hope you all have a good Friday, if indeed that's where you're at, because we know we have international people joining us. So thanks again, and look forward to next time.